This is Sandy Biber from Mass Rehab, and it is my pleasure to introduce two clinicians who work with Mass Rehab who will be starting us out this afternoon. Dr. Jeff Shear is a board-certified clinical neuropsychologist who's been practicing neuropsychology in the Boston area for over 20 years. He completed his undergraduate work at Boston College and both his master's and PhD at the University of Victoria in Victoria, British Columbia. Dr. Shear's clinical interests and focus of practice have been primarily in the area of rehabilitation neuropsychology, and he has extensive experience working with survivors of stroke and traumatic brain injury. He's been consulting staff for inpatient care at both Spaulding Rehabilitation Hospital in Charlestown and Spaulding Hospital for Continued Care in Cambridge since he completed his postdoctoral training at the Harvard Partners Neuropsychology Consortium in 2004. Dr. Shear also runs an outpatient neuropsychology practice in Charlestown, Mass. Dr. Shear more recently joined the Massachusetts Rehabilitation Commission team, where he served as a neuropsychologist consultant for both the statewide head injury program and the HCBS waiver programs. Denise Permateo is a licensed individual clinical social worker, LICSW, who's been practicing primarily in the area of adult mental health for over 15 years. Her background includes work for various Boston area teaching hospitals as a medical social worker, as a consultant to long-term care facilities and adult day health programs, and to mental health treatment, and as a mental health treatment provider for community agencies in both the outpatient and psychiatric emergency services. In addition, she previously ran a private practice providing cognitive behavioral therapy and supportive counseling. Currently, she works as the mental health consultant for the Massachusetts Rehabilitation Commission's MFP waiver and SHIP programs.
Good afternoon. I'm Dr. Jeff Shear, and I'm going to start us off this afternoon. And for our part, the next hour or so, what Denise and I are going to do is try to live up to the really high bar set by Dr. LaVecchia last week in her talk. But this week, we're going to shift our lens from the cognitive and neurobehavioral disorders and how they may affect participant behavior and how to interact with them to the role of mental health and psychosocial complexities on our consumers' behavior and how those are going to play out, both in terms of your day-to-day interactions as waiver staff, but also in terms of what you might want to think about when you're having a conversation about the principles of engagement. So in terms of our goals and objectives, we have been tasked with first reviewing the eligibility criteria and providing a picture of the clinical makeup of the waiver population, including many of the challenges and experiences that you may have when working within this population. That's going to be followed by a brief overview of select mental health diagnoses and psychosocial factors that may affect participants. And while it's interwoven, we're also going to be discussing some considerations for presenting the principles with these specific participants. Beyond these specific goals for our talk, I want to also add that in the larger scheme of this series, we're hoping to do two things. We want to increase awareness of the factors that may contribute or exacerbate a person's behavior, and to maximize successful and clear communication about the principles of engagement when they're being presented. So let's start with reviewing the waivers. So this may be a review for many people, but in case you're less familiar, there are a total of 4 waiver programs, 2 of which are residential and 2 of which are community-based. The residential waivers are managed by DDS and include the ABI-RH waiver and the MFP-RS waiver. Community-based waivers are managed by MRC, including the ABI-N and the MFP-CL waivers. In terms of understanding the eligibility, in order to qualify for the ABI waivers, you need 4 things. The first is standard for all waivers, and that's the individual is anticipated to be in a nursing facility or a chronic disease hospital for 90 days or longer at the time of application, with the goals being to facilitate individuals with a transition out of the long-term facility and into the community to as great an extent as possible. For ABI, you have to be 21 or 22, financially eligible, and as convention would have it, you must have an ABI. For residential, you need to require 24/7 care, and for the non-residential waivers, individuals need to not require 27 hours, 24/7 care, and be able to be safely managed within 84 hours per week, which can include a combination of informal support and other state plan services. So when we said acquired brain injury, there are very specific injuries that are necessary to meet the eligibility criteria. Actually, individuals with these diagnoses are likely qualify for either the ABI or the MFP, but the diagnosis would be required for ABI. And these diagnoses would include traumatic brain injury from an externally caused TBI, a brain tumor, a vascular event such as a stroke or an aneurysm, or injuries classified as metabolic, infectious, or neurotoxic. So an example of metabolic might be an anoxic brain injury. Infections might be like a bacterial meningitis, which is an infection of the meninges of the brain, or HIV encephalitis, which is an infection of the brain from HIV virus, and et cetera. Also, injuries acquired through toxic exposure, like metal poisoning or carbon monoxide poisoning, would also qualify. So these are qualifying diagnoses for ABI. By contrast, when we're talking about the MFP waivers and eligibility, again, we have the 90-day requirement, but here the individuals that are eligible are adults who are 18 to 64 with a disability, which can be either a physical disability, mental illness, or both, elders age 65 or older, and again, residential candidates require 24/7, and community-based candidates will have less than 24/7 care and can be safely managed in the community. All right, now in comparison to ABI, that is a much broader category. So let's take a look at who might meet those criteria. So this is a complicated slide, and this is by no means anticipated to be a comprehensive list, but we've broken this into several different categories that I think provide pretty good coverage of a lot of the consumers that may be in the waivers. First of all, we have other neurological disorders. As I mentioned before, ABI only includes a specific portion of neurological disorders, but there may be others not on the list which can cause disability. For example, neurodegenerative disease or dementia. Alzheimer's and vascular dementia are going to make up the largest part of this population, but you might more rarely see individuals with other dementias, such as Parkinson's disease, Huntington's disease, or frontotemporal dementia. Muscular sclerosis or multiple sclerosis can also cause both cognitive and physical disabilities, as we know, and spinal cord injury can cause significant disability. There are a large number of individuals, from the next column, who have complex medical conditions. So going by system, they may have cardiac issues like hypertension, coronary artery disease, atrial fibrillation, congestive heart failure. There may be pulmonary issues like COPD, asthma, or pulmonary embolism. Renal issues like end-stage renal disease, orthopedic or dermatological issues like arthritis, wounds, or severe fractures, or endocrine issues like diabetes and thyroid. There are going to be a large number who have psychiatric disorders as well, which, as we said, can be an eligibility criteria in itself. But we're going to go into that in a lot of detail today, so I'm not going to go through those right now, but they include the categories you see there. In terms of developmental disorders, while the target population is adults, there may certainly be participants whose disabilities involve developmental issues such as cerebral palsy, attention deficit disorder, learning disorders that can be complications to their status. And of course, many of our consumers can have primary or comorbid substance use disorders, ranging from alcohol to opioids in the context of the current opioid epidemic, to misuse of other substances. So those are some of the qualifying diagnostic categories that are going to be common in the waiver programs. And while they may seem to fit in nice little boxes or categories, one of the things that we all know by now with this population is it is extremely complex. And what we need to do is embrace the complexity. People do not fit neatly into those little boxes. Even within diagnosis, there's going to be considerable diagnostic variability, and one individual with MS may look very different from another, and so forth. Comorbidity also abounds. As we see, these factors can be significantly intertwined, and it's likely that people are going to have multiple issues. If that isn't complex enough, you may find a great deal of diagnostic mystery. particularly surrounding mental health. While there's a high rate of mental health pathology in the population, it's also very safe to say that there's a high rate of undiagnosed mental health issues that don't come to light until the individuals become consumers. Even for those who have a past medical history of mental health issues documented, if there are no current treaters, you may not have access to accurate information or recent diagnostic formulations, and there can also be errors in the record. So for example, when we think about this all together, it may not be at all clear that our individual who becomes eligible due to a spinal cord injury also has a significant history of substance use, major depression, a personality disorder, or many other issues that have never been evaluated for. But then those issues become factors or significant factors within the care of the waiver. Just to emphasize these points, I do have some data. Let's start with some numbers from MFP. These are regarding non-medical factors. And as we look at this data from UMass, first we see that a lot of individuals have acquired brain injury, even in the MFP, which speaks to the overlap that I mentioned before. We also see some moderate numbers of mental health and substance use disorders reported. But remember, we may only be seeing diagnoses that have come across through eligibility reviews, and for the reason of eligibility, may not have included full awareness of other mental health or SUD issues. So it's probable that those numbers may actually be low underestimates of the reality of the population. If we look at some data provided by DDS regarding the Northeast region, we again see broad representation of diagnoses. So there's 57 to 77% of individuals who are considered medically complex, 40 to 46% with substance use, or 52 to 67% with mental illness across the two waivers. If we look at the numbers in red, we see roughly 30 to 40% who can be considered dual diagnosis. So when we think about those data points alone, we already see comorbidity abounds. Here we also see a higher degree of reported issues than in MFPCL, which may have to do with the increased complexity to some extent of individuals in RES, but may also just be explained by reduced recorded diagnosis initially in the CL community. I'm not exactly sure. So to this point, we've been focused mostly on diagnosis, but when we're thinking about the waiver of populations, again, we need to embrace the complexity. It's important to remember that people are complicated, and given that the waiver programs are designed by nature to support care for vulnerable individuals and populations, there's going to be a significant degree of overlay of psychosocial factors. For example, you may work with individuals who have had limited educational or occupational achievement, including individuals with less than high school education, learning disorders or undiagnosed learning disorders, or reduced literacy. That may in turn lend itself to limited professional work history, unemployment or underemployment, lack of opportunities due to low education, resources, or geographic location in which they reside. Underemployment may also arise from disabilities themselves if they're acquired at an early age or during someone's prime earning years and interfere with somebody's ability to engage in educational or work opportunities. Individuals with in this population may consist of people who also have fragile support networks, who have experienced abuse in their upbringing or adulthood, have experienced domestic abuse. They may have strained or estranged family ties and little in the way of ongoing support or even just interaction with family and friends. On the CL end, we may have many individuals who are simply home alone all day, day in and day out. You may encounter people who have had a long forensic history, or perhaps a recent forensic history, including individuals who have a history of incarceration, and in some instances that I've heard of specifically from the DDS coordinators, individuals who have committed some pretty significant crimes that may have even been a surprise because they were not prosecuted or convicted and it wasn't initially in their record, but came to light later. There's also economic challenges, and the individuals may be at or below the poverty level, experience homelessness, or be marginally housed. So while we're talking about homelessness, there are also clearly additional risks and challenges specific to those individuals. They may be people who are vulnerable to injury, illness, or crime due to their lack of stable housing, be at high risk of mental health, substance use, or TBI being unrecognized misdiagnosed or untreated, have a lack of general medical oversight or access to care, decreased monitoring of chronic conditions, difficulties adhering to a medical regimen or access to medication, or poor follow-up with discharge instructions and care. Okay, so these are some of the many challenges that you may find within all of the waiver populations, but I just want to take a minute to talk a little bit about some of the similarities and differences between RES and CL and the risks associated with each environment. The first major difference between RES and CL is obviously the structure of the environment itself. In both settings, as staff, you may face risk from a participant themselves, but in the structured environment, there are very likely to be people around who could help you if you did need support with some behaviors. However, in the community, it's possible that you may be more isolated. Furthermore, the environments themselves are also different. So if you think about situations with things like weapons or substances, it's certainly possible that a consumer may try to bring these into RES, but in the community, there may be an increased risk that consumers have weapons or substances in the house that may put staff in challenging positions for a variety of reasons. Next, I've listed casts of characters or people you may encounter. Obviously, many participants are going to have a network of supports, friends, or other people in their lives, and those people may have effects both on the participant and the staff provider. Some may be stabilizing factors who calm the participant in the situation. Some may be deep stabilizing factors who agitate or goad the consumer. Some may be destabilizing factors for you when you're working with them as opposed to consumer. As we were talking about the principles, we received at least one example from staff who was working with a very pleasant participant, but another person who lived in the house was very rude and abusive and more of a source of difficulty than the consumer herself. These situations, again, can certainly happen in RES as well. A visitor, a phone call can be very disrupting or destabilizing. But there may be equal or greater challenges when you're going out into the community because you do not know who may be there or show up unexpectedly. Finally, I have entering somebody's home. And this is a situation that's similar to the last, but when you enter somebody's own home or personal space where they have lived their lives, they've developed their own sort of personal or family subculture, and there may be different belief systems, and they may also be very comfortable and perhaps more emboldened to say or do things that they might not say or do in other settings. And again, can certainly happen in RES, which is also very clearly someone's home, and they may be plenty emboldened, but the dynamics may be slightly different. So now I'm going to hand it over to Denise, who is going to start us off regarding several specific of the mental health disorders and how they may affect behavior. And I'll be back later to assist with that before we end on some additional notes on the interaction of behavior and the principles.
Good afternoon. Thank you, Dr. Scher. So yes, I will be presenting today on mental health and the waiver population. I would like to start with a nice description from the CDC on what mental health is and its impact on the whole person. Mental health is an important part of overall health and well-being. Mental health includes our emotional, psychological, and social well-being. It affects how we think, feel, and act. It also helps determine how we handle stress, relate to others, and make healthy choices. Mental health is important at every stage of life, from childhood and adolescence through adulthood. At the bottom of the screen, I also noted a simple statement that I always find helpful in understanding and remembering the impact of mental health disorder on functioning. The experience of a mental health disorder can alter how we perceive the world. Today, I'm going to focus on some of the common diagnoses you might experience working with the waiver population. I will list and describe some defining features or symptoms and the potential impact these mental health disorders may have on your interactions with your participants. We'll talk about mood disorders, anxiety disorders, personality disorders, thought disorders, and substance use disorders. We're first going to look at mood disorders, starting with a few risk factors. There are biological, psychological, and environmental risk factors. A biological risk factor is a genetic predisposition or family history. A psychological risk factor could be familial trauma, such as childhood abuse or neglect, individual trauma, collective trauma, which we could include the current pandemic we've all been living through, and then disasters. And environmental trauma might be loss of employment, grief and loss, a medical illness, or living environment. So under mood disorders, we are going to look at depression first. Some of the symptoms or features that you may observe with someone that is suffering from depression could include low mood, intense sadness or despair, suicidal ideation with or without plan, loss of interest in activities you may have once enjoyed, withdrawal from friends and family, social isolation, restlessness or agitation, or alternately, psychomotor agitation, which is just slowed down speech or movements, difficulty with concentration, indecisiveness, or sometimes there could be a more severe cognitive depression, which is pseudodementia. And pseudodementia is someone that is experiencing a significant depressive episode. It also could be untreated or undertreated, and they may exhibit symptoms that could mimic dementia, such as confusion or short-term memory. Some of the different types of depression or diagnoses are major depressive disorder, so the symptoms that I just described above could be part of a depressive episode. Dysthymia, which is a milder, less severe depressive episode. It's more of like a chronic form of depression. Seasonal affective disorder, which typically occurs starting late in the fall when there's less sunlight, around the time that daylight savings might start. And through the winter, people are indoors more, isolated more. And also, you could have depression secondary to a medical condition, such as a spinal cord injury or maybe a cancer diagnosis. Next, we'll discuss mania and bipolar disorder. Some of the symptoms of mania could include an elevated or expansive mood, exaggerated self-esteem or grandiosity. And grandiosity just means that someone is verbalizing, exaggerating their achievements, such as, I'm the best in the world, there's nobody who does that job like me, or sort of constantly boasting. There might be less need for sleep, talking more than usual loudly and quickly. They may be easily distracted or engaging in many activities at once or risky behaviors such as reckless driving or spending sprees. And today we'll look at briefly bipolar 1 and bipolar 2. In bipolar 1 disorder, you need to have a severe manic episode. So basically, the symptoms that I noted above are present, and your functioning is typically going to be significantly impaired. So your occupational functioning, you might lose your job, academic functioning, relationships will suffer, etc. There sometimes could be a major depressive episode as well, but it's not always present. It's not required for a diagnosis. For bipolar 2, the individual will experience more of a hypomanic episode, which just means that the symptoms are not as severe or as heightened as a full manic episode. And also with bipolar 2, you may not have the significant impact on functioning that is required for bipolar 1 disorder. So we're going to look at for a moment the impact on interaction with depression and mania. And these are some of the features that you may see when working with someone. So if someone is depressed, they might be lethargic, unable, or unwilling to respond. There could be low or poor engagement. They could be cognitively depressed with pseudo dementia and it hasn't been diagnosed. They could be overwhelmed. There could be poor follow through, poor medication compliance, such as the person could say, I don't see the point of taking any medications, or they haven't had their medication regimen looked at in a while. There could be a low mood, of course, but also the person could be experiencing an irritable depression and be angry with your interactions with them. With mania, the person is going to be very talkative. You can't get a word in edgewise. It's going to be very difficult to redirect them. Their thoughts are going to be moving very quickly. So that could result in them being unable to process what you are saying. They're going to be very distracted, very tangential. They also might not feel the need to take medications. There might be an insight issue with feeling like they don't need medications. And they may also overestimate their ability and functioning at that time. So anxiety disorders. So I have 3 columns here. And the first column we're going to look at is the blue one on the left, which is anxiety disorders. And we're going to talk about some of the symptoms and features. So we'll start with restlessness. Someone may be on edge, very restless, excessive worry or fear, an inability to concentrate, poor sleep. They could have insomnia or trouble falling asleep, staying asleep, waking up many times during the night. There could be physical symptoms like sweating, rapid heart rate, dizzy, lightheaded, nauseous, and there could be avoidance of activities related to the anxious fear. And then in the middle column, the purple column, we have obsessive, compulsive, and related disorders. Some of the features could be rigid behaviors and thought processes, rituals such as excessive hand washing, maybe checking the lock on your front door 25 times before exiting the home. There could be a hoarding behavior. And some of the diagnoses or the types could be obsessive compulsive disorder and hoarding disorder. And then the last column we have is trauma and stress-related disorders. So the person might experience flashbacks, nightmares, or hypervigilance due to experiencing a traumatic event. And the types of a trauma and stress-related disorder would be PTSD or an adjustment disorder. So impact on interaction. So if you're meeting with someone and they're experiencing various forms of anxiety, some of what you may experience or observe could include the following. They may be easily triggered with known and unknown factors. So sometimes a person is aware of what is triggering the anxiety or panic, and sometimes they're not aware. Avoidance of a perceived threat, so avoidance of a trigger. Panic attacks, fear of the unknown, poor follow-through due to avoidance. There could be a fight or flight reaction, and because of that fight or flight reaction, their response may be more aggressive or really agitated due to a trigger that caused that fight or flight response. There could be worry or fear regarding a medical intervention, so anxiety around needles, pain, or medications. And there could be rigidity, and they may be very difficult to redirect during this anxious period. So we're going to briefly go over personality disorders today. We're going to start with what is a personality disorder. So I have a brief description for you. A personality disorder is an enduring pattern of behavior that can be pervasive, inflexible, and leads to distress or impairment. I've noted some general features of personality disorders, such as a negative impact on interpersonal functioning. So the person could have maladaptive coping skills, maybe unhealthy patterns of thinking and behaving. Also impacted is how one perceives the world. They will have significant problems and limitations, usually in relationships, social activities, work, and school. Personality disorders cannot be treated with medication. There are a range of personality disorders such as antisocial, avoidant, borderline, dependent personality disorder, histrionic, narcissistic, paranoid, schizoid, and schizotypal. But today we're only focusing, due to time, on 3 personality disorders. So we're going to look at borderline, histrionic, and antisocial. So I have 3 columns up, and we're going to start with the blue one. We're going to look at borderline personality disorder. So borderline personality disorder impacts the way you think and feel about yourself and others. There are typically problems functioning in everyday life, difficulty managing emotions and behaviors, patterns of unstable relationships as well. Some of the hallmark features can be frequent high conflict relationships, a fear of abandonment. There could be self-harm, for example, in the form of cutting. There can sometimes be frequent suicidal ideation, verbalization of suicidal ideation, and dysfunctional thinking styles such as catastrophizing or all or nothing style thinking. Next, we'll talk briefly about histrionic personality disorder, the purple column in the middle. So histrionic personality disorder means that someone typically has a very poor sense of self and that their self-esteem is dependent on approval of others. A hallmark feature with this personality disorder is an overwhelming desire to be noticed. Behavior is really driven by a need to be the center of attention, and the individual's behaviors can reflect that. When not the center of attention, the person may become depressed. They may behave dramatically or inappropriately to get that attention. They will also have a dysfunctional thinking style. And something that you might experience is that this person suffering from this disorder will be very impatient. So there may be a need for immediate gratification. Basically, like everything is an emergency. They need answers now. Their life depends on it to get answers immediately. In the last column, we have antisocial. Antisocial, the defining features can be a lack of remorse, empathy, or concern for others. This individual may not think twice about violating the rights or feelings of others. Some of the features could be no respect of lawful behavior. They may be deceitful. They will lack empathy or remorse and will be very indifferent to mistreating, hurting, or abusing others. So, how does a personality disorder develop? Briefly, I am going to say that there are environmental factors, which could be childhood abuse or neglect. For example, did someone not get important needs met as a child? Or there could be genetic factors. So again, this was just a very brief intro description about personality disorders. But we'll move on to impact on interaction with personality disorders. So an individual may engage in inappropriate behaviors, have poor or even no boundaries, and in turn may have difficulty respecting others' personal boundaries. They may perceive the boundaries as a form of rejection and may push limits. For example, perhaps say calling or texting 15 times a day. This is a good example of someone that may have borderline personality disorder, but could also be seen in histrionic and maybe some of the others as well. The individual could engage in provocative behavior, may say or do something to try to elicit a response or a reaction from you. For example, if you're working with them, perhaps they might say, well, you don't know your job, just to see what your response is, to elicit a response from you. The person could engage in accusatory behavior, making unfounded statements, and may be manipulative, trying to get you to do things beyond your job. And so with unremorseful about criminal activity or hateful speech, that would really apply likely to antisocial personality disorder. They really don't care with antisocial if the behavior is not only illegal, but is upsetting to others, upsetting to providers. So we are going to move on to thought disorders. A thought disorder is when someone has trouble creating logical sentences through speech and or writing. And this slide is going to be most about schizophrenia features and other psychotic disorders. So some of the features with the thought disorder could be hallucinations. So we have visual and auditory hallucinations. Visual is, you're seeing things that are not there. Perhaps shadows or people or animals. And auditory, you might be hearing things that aren't there. So you could be hearing voices or other sounds. And the visual and auditory hallucinations are not based in reality, so they don't exist. There is delusional thought content, such as paranoid, bizarre, or disorganized. So if someone's paranoid, they may make statements like, they are out to get me, or I am being followed, or do you hear that radio? They're listening to my thoughts. Or I work for the FBI as an agent. So that's an example of some of the delusional thought content, paranoid, bizarre, or disorganized, that you might observe with someone you're working with. Also, another example could be the thought disorder feature, thought broadcasting, when the person is thinking of something and feels that they are sending or broadcasting their thoughts to another person or others. So all of these thoughts are not obviously based on fact or in reality, but it can feel real to the person that is experiencing them. They also might have a cognitive impairment, could have a mood disorder. A range of the diagnoses that could fit under a thought disorder is schizophrenia, schizoaffective, and delusional disorders. So, the impact on interaction. Someone might be acutely psychotic when you go to meet with them, as you are working with them. They might be acutely psychotic. They might be experiencing the hallucinations or the disorganized or bizarre thoughts that we just went over on the previous slide. They might be paranoid. They might find you threatening for very unclear reasons. There might be unexpected reactions or thoughts to what you are saying to them. There could be a neurocognitive disorder and problems with memory and attention. So you don't want to argue typically with someone who is in the middle of this psychotic episode, who's delusional and has poor reality testing. It would be best not to challenge what that person is thinking, what their ideas are at that time while they're in that current state. And likely, it would be best to wait and engage with them at a more appropriate time. And now we're going to move over to substance use disorders, and I'm going to hand it back to Dr. Scher.
So I'm just going to go through one more of these slides, but one more of these mental disorders, and then we'll go through some other material. A lot can be said about substance use disorders, but I'm going to try to keep this concise and just talk a little bit about DSM-5. So in DSM-5 currently, which is a change from the previous iteration for thinking about how psychiatric issues are classified, substance-related disorders are now separated by the class of drug and include 10 different classes of drugs, which are listed here. Within each of those, there's a breakdown that acknowledges the distinction between a substance-induced condition and a substance use disorder. So a substance-induced condition is what we think of as problems that arrive when a drug is actually on board or the medical effects of that substance. So these might include things like intoxication, withdrawal, or other substance or medication-induced mental disorders. For example, when somebody is on a substance, they might develop a substance-induced psychotic disorder or a substance-induced depressive disorder. So those would be substance-induced conditions. By contrast, substance use disorders describe a cluster of cognitive, behavioral, or physiological symptoms indicating that the individual continues to use the substance despite significant substance-related problems. For example, the person who continues to drink despite the fact that the behavior has caused very significant problems in their lives. It's a pathological pattern of behavior surrounding the use of the substance. And from the list above, certainly alcohol and opioids with the current opioid crisis are issues that you may encounter a lot. And I just want to add a quick note that while alcohol, caffeine, and cannabis are legal in Massachusetts, they may still be misused. So there can be a host of extremely broad challenges and problematic behaviors that can be associated with substance use disorders, but just to scratch the surface, you may experience individuals that are high conflict, aggressive, or shut down, particularly surrounding any discussion of their use. There may be challenges related to substance-seeking behavior, leaving the unit or the home, trying to elope to seek substances in a situation that may get themselves hurt. There's the potential for injury, both to themselves or others, particularly when intoxicated. And there may be long-term effects on the body leading to chronic medical conditions like vascular issues, liver disease, or neurological problems. And in terms of how it's going to affect your interactions, you may experience people who are in denial. That's a big one in this population, combative or confrontational, or have poor engagement in self-care or interest in care. Now that we've taken you on a brief tour of DSM and various psychiatric disorders and how they can have an impact on your interactions in health, I just have a few more slides as we close out to talk about the psychology of health, as well as some of the difficulties that we face with the problems that have led to the development of the principles. So first, when we think about behavior in general, we have to appreciate that behavior has a significant relationship to medical status. And regardless of the setting, there are some challenging behaviors that seem particularly problematic for all of us as providers or individuals who help participants. And some of these behaviors include refusal of care, whether it's refusing to engage in substance use treatment, mental health treatment, or even medical treatments. Non-adherence to medical recommendations, whether it's not following transfer restrictions, not being careful about diabetes management, or not wanting to maintain sobriety despite the fact that you have cirrhosis, liver failure, and other problems. Or reduced engagement or willingness in discussing risk factors. And again, as providers, these things can be really hard to understand and appreciate. So these behaviors in particular highlight a complex interaction between psychology, cognition, and background personal beliefs that can affect behavior and in turn affect our medical status and vice versa. So sometimes these behaviors can be very heavily influenced by a full-blown neurobehavioral disorder, as Dr. Lavecchia discussed. For example, the brain-injured individual with absolutely no memory who can't remember to take meds, which leads to non-adherence. Or the brain-injured person who doesn't have insight, which leads to non-adherence with safety precautions or reduced engagement in treatment. In these instances, the cognitive factor may really tip the scale in their decisions, affect their behavior, and have an adverse effect on their medical status. Similarly, as we have seen with somebody who's manic and may not believe that they need a medication or have grandiose thoughts about their own capacity, the psychological or psychiatric factor may tip the scales of behavior and have an adverse effect on their medical status. But even for people without a clearly diagnosed mental disorder, there's a spectrum of behavior regarding willingness to engage in various behaviors. There may be other factors related to your cultural beliefs or personal beliefs that influence your behavior. There are people with COPD who make decisions to continue to smoke. There are people with diabetes who elect not to follow dietary restrictions. People who would rather use ladders even though they have balance problems, or would rather transfer themselves to the bathroom rather than call for help no matter what because of a matter of pride and dignity. There are people who want to drink, use recreational drugs, or even eat the wrong thing. Myself included for the eating the wrong thing part. These are choices that we all make. Sometimes they are extremely hard choices, and sometimes there are habits that are really hard to break. It can be difficult to break our nature, and we may not want to hear what people are telling us. The point is that there's a complex psychology that leads to choices, that lead to behavior, which can in turn have effect on our medical status. And people may not like the choices that we make, and we may not want to hear what they have to say, which leads to difficult conversations. So when I think about this talk and the principles in general, I think there's also an analogy here to our conversation about having difficult conversations. Behavior is complicated. And when we think about abusive or racist behaviors, the behavior can also be complicated. There may be many contributing and exacerbating factors that explain why someone may make the choice to engage in abusive behavior or rhetoric. There may be clinical reasons that emerge, such as medical or psychiatric causes of disinhibited behavior, like with traumatic brain injury or mania. Some people may be emotionally dysregulated or intoxicated and also say things that they will regret. There may be situational reasons that can exacerbate a situation. The person who's in severe pain and feels pain during care and then lashes out. The person who's angry about a recent incident related or unrelated to care, but then you walk into their foul mood on that day and they lash out. There may be interpersonal, personality, or cultural reasons, such as high conflict individuals with personality disorders who may want to be or are very comfortable with being antagonistic and provocative in their behavior. As we spoke before, there's also maybe a personal subculture of an individual in their family or home, and within their personal subculture, they may prescribe to a very different set of beliefs that affect their behavior. So again, people are complex, and in conclusion, I think as we talk about the principles and working with our clients, I want to emphasize that our larger goals here have been to increase awareness of factors that contribute or exacerbate a person's behavior. And I hope that Dr. Lavecchia, Denise, and I have helped to some extent with that first goal, and maybe to some extent with the second goal. which is to maximize successful and clear communication about the principles of engagement. But now what we're going to do is dig deeper into that second goal, and Dr. Susan Roberts will make sure that we get there as she discusses positive behavioral supports and some concrete and pragmatic ways to go about your conversation. Thank you for your time.